Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in our conversation with cancer expert series, we have one of the leading researchers in the Menin space, Dr. Suresh Balasubramanian, who's assistant professor at Karmanos Cancer Institute at Wayne State University in Detroit, Michigan. We're thrilled to have him, and welcome, Suresh.
Pleasure is mine. Thanks for having me here. It's been a great association in the past couple of years, talking about different topics. And I'm more excited to talk about menin and menin inhibitors, which has been one of my primary interests in the past few years. Thank you.
So, just a primer for those who are not as well aware. Can you just give us a little background on menin and its role in AML?
Sure. I know the audience is pretty wide, and I just want to go to the basics to make us all understand. Menin is the same protein that we have heard back in the days when we talk about a syndrome called MEN1, which is multiple endocrine neoplasia, in which the MEN1 gene is mutated, and it causes the syndrome with all the tumors that would arise. So essentially, a tumor suppressor protein in that context. What was learned in the past 25 years or so, that menin also is a tethering protein or a scaffolding protein. It scaffolds multiple other units that are responsible for regulating gene expression programs. And what was found in the past 25 years is very interesting part is like menin was scaffolding something called KMT2A rearranged leukemias. And in KMT2A rearrangement is one of the molecular signatures that drives leukemia. Primarily in pediatric population, but at least 5 to 10% that you can see in adult population too. And in KMT2A rearrangement, what happens is KMT2A fuses with multiple other fusion partners, and that drives the leukemia through a program called HOXA9 and MEIS1. What was discovered was menin was responsible for this fueling mechanism to be driven. And when this menin interaction with this KMT2A complex was inhibited, you had seen downregulation of HOXA9 and MEIS1, and eventually, led to differentiation and leukemic cell death even. So this was more preclinical that evolved in the past 2 decades. When they also discovered that what is interestingly was pretty sensitive in another signature of AML, which was NPM1-mutant AML, where one might even think there is no KMT2A rearrangement. How does it work? But even if menin's interaction is inhibited with the KMT2A wild type status, which is essentially true in NPM1 mutant leukemia, it was anti-leukemic. So these two signatures have been primary targets once the drugs, small molecules, were developed to target the menin's interaction with the KMT2A complex. And both these signatures are primarily studied in AML right now across multiple early phase studies and more registrational studies recently in a couple of drugs.
So obviously we have two menin inhibitors, and there are more to come. I think what would love to see is what your take is on what differentiates these menin inhibitors. The earlier trials will just concentrate on the composite because we want to get on to where the field is moving, which is into earlier line, frontline treatment. But yeah, let's start with where these started first in relapsed refractory disease, and what do we know about these?
Yeah, it's a fascinating story. Looking back in the past, historically, we have just treated with cytotoxic chemotherapies, and then moved on to a differentiating agent like ATRA and arsenic in APML. We can cure majority of the patients. And then there was a huge pause in the developmental program And we found, targeted inhibitors targeting signaling pathways like FLT3 inhibitors, and then looking at specific point mutations leading to epigenetic changes like IDH inhibitors. Those came in development. And this is a pretty unique target, like where the transcriptional regulator like menin has been targeted, and where its interaction getting inhibited, changing the way the downstream signatures would change and cause anti-leukemia. It's good to know that there are multiple inhibitors in pipeline right now, and some of them are towards the registrational stages of clinical trials, and many of them are in the developmental stages at this point. It's very interesting. Like in CML, I can relate to there are multiple inhibitors, but they all were uh, coming sequentially. But here it's like all going to flood at the same time. And it's great. It's great just because we'll have many options for the patients, and based on how these are going to pan out in terms of results. What I could tell from the relapsed refractory space, those clinical trials that are listed here, and of course, some of these numbers are actually getting updated with more recent data that are published, especially with the Augment 101 and the ziftomenib's Comet 001. And the other drugs which are closely in line and getting back to each other is the bleximenib and enzomenib. If you look at revumenib, which is the first one to get approved in the relapsed refractory space, was in KMT2A rearranged leukemias, and this is exactly what this data is showing about and supporting the same. There is an updated data and that was published in Blood in 2025 that led to their increased coverage and made them approved for NPM1-mutant AML space as well. If you want to compare these side by side, I think it'll be great to put them based on molecular signatures. If I have to put them based on molecular signatures, the CR/CRc rate is around 23 to 24%, like across both, revumenib and ziftomenib. So I would think with those two drugs that are being approved already in the NPM1 mutant space, the response rates in the relapsed refractory setting for those two drugs that are approved already are similar. Like it's not a whole lot different considering the number of patients that has been treated so far. But what is promising about these numbers is that if we can get a CR/CRc in a heavily treated AML population where there was no treatment that was existing, I think it would make many patients become transplant eligible if they have a deeper remission and consider for a more definitive cure in that setting. So I think it has opened up the space to more promising treatments like this to help navigate patients during relapse setting and then eventually take them for transplant in some eligible patients. Even if they are not transplant eligible, I think there is some meaningful responses that are seen here with the overall response rate. If you look at revumenib's KMT2A rearranged data, it's around 60%. So what is listed here? And the rest of the response rates are pretty much, I would say, similar. Some of these numbers are smaller, so on a bigger scale, I'm guessing they all will pan out around the same time, around the same area. Ziftomenib is not being developed as a single agent in KMT2A rearranged leukemia, and it's primarily for the NPM1 mutant space. So the indications are slightly different for ziftomenib in the relapsed refractory setting. But overall, what I see here is pretty promising, response rates in heavily treated AML subset where there was no targeted treatment available prior to this.
And how do these compare on the toxicity front?
That's an interesting question. We are actively learning how these are behaving. At least in the response rates, they are pretty much similar, in my opinion. Of course, there are like some, minor percentage differences, which I would think, in a larger scale, when we are using in the real world, are going to pan out around the same ballpark. Interestingly, menin inhibitors, as we have seen, IDH inhibitors or like ATRA and arsenic, they all can cause differentiation syndrome. But the differentiation, syndrome that I have personally seen with menin inhibitors is quite unique. It's more, florid and robust differentiation. Of course, it's an on-target side effect, but one should definitely be wary about it, and recognize it earlier and treat it appropriately. Differentiation would be a class effect of menin inhibitors. And of course, everyone has reported some sorts of differentiation syndrome in all these AEs that has been reported so far across all the drugs that is in the pipeline. So that is going to be a class effect. And with respect to what signatures are more prone for differentiation, say, for example, KMT2A versus NPM1, and I think the data is still not mature enough to recognize, meaning we need to see larger numbers. But definitely, that is a class effect that we have to be, worry about. And then the biggest thing is about the QTC prolongation across these small molecule inhibitors. The QTC prolongation for the two drugs that has been approved so far, which is ziftomenib and revumenib in the NPM1 mutant space, and revumenib in the KMT2A-rearranged space as well. It is known that both can cause QTC prolongation, but what is uh, interesting is that revumenib probably has a slightly higher overall QTC prolongation rate, maybe three times more, at least in the overall levels. But if you look at more of grade 3 QTC prolongation, definitely revumenib probably has more occurrence of events compared to ziftomenib, and ziftomenib does have some QTC prolongation, but not to that extent of ziftomenib does. So there is definitely, like, both are menin inhibitors so far approved in this space, but there is definitely difference in the side effect profile, especially with respect to QTC prolongation. Bleximenib patients, it's a very early yet to say like what is their published data going to be, but I won't be surprised to see some sort of a QTC prolongation across all these menin inhibitors at some point. Maybe one may not have it, but we do not know yet until the data becomes like publicly available and published. What are the real numbers and how did they mitigate it? What is shown in the trial, though, there is some dose reduction or interruption needed more with revumenib than with ziftomenib. There's like 1% versus like 11% when you compare it for dose reduction. So in that regard, like ziftomenib has probably a favorable safety profile in terms of QTC prolongation. And apart from that, cytopenias, it's hard in especially heavily treated AML population where they have a poor bone marrow reserve. But cytopenias are seen, across menin inhibitors again. But I think more data needs to be known about like how these pan out in the longer run and how sustainable are these cytopenias. Do they recover these counts? Real world practice will let us know like how these will pan out.
So, for the NPM1 mutated patients for which both are approved, do you have a way to choose between them, or they're pretty interchangeable at this time?
It is very difficult, to be honest. So both are approved in this space, and I think I would probably think that insurance would have payers, would have a say in terms of what their preferred agent would be, and I think that will have a bigger influence too. And I think that probably is one of the least things to be considered, of course, but it's a major, it's a major player. But apart from that, if I look at the efficacy data, I don't think they are two different things. Like efficacy is pretty much the same. And I think a part of it would be the comfort of using these drugs. A provider who has been has more experience using revumenib would probably prefer revumenib, and provider has experience using ziftomenib would have preferred like ziftomenib, since both are approved in the NPM1 mutant space. But with regards to side effect profile, if there are clearly like underlying comorbidities, with say for example, if you're treating an elderly patient with cardiac comorbidities and underlying QTC issues, then probably a favorable drug would be ziftomenib. If that's not the case, you're treating any younger patient and QTC is not an issue, and I think it's almost a flip of the coin right now.
What about drug-drug interactions?
um, you know, the drug-drug interactions are kind of common for almost these two inhibitors. So, for example, like there is encouragement for using ziftomenib, menib with antifungals like CYP3A4 inhibitors because it increases the levels more favorably. But of course, these drug-drug interactions are inevitable in the small molecule inhibitor space. But so far, like whatever we have done is all patients being on clinical trials, we were able to, give them the appropriate antifungals and, continue the treatment as such. But there are some issues with, how if a patient is already on a proton pump inhibitor or an acid reducer like that of a kind of a drug, it needs to be spaced apart. So there are, clear directions of how we should be using these drugs. But I think we will have more experience when it comes to real life practice as well.
So let's shift gears to where these drugs are going now. Obviously, they're moving into earlier line, frontline therapy. So let's review some of the studies with these various compounds. So I guess there's this AML master study that has a sub-study looking at revumenib with venetoclax. Can you just briefly describe the study and let's review what we know about the results?
Yeah, I think we were expecting this to happen, and it was happening simultaneously when these relapse refractory clinical trials were ongoing. It was not surprising because anything that works in the relapse refractory setting has to be moved up. This is essentially patients who are more than 60 years with AML, who are unfit for intensive chemotherapy. And either NPM1 mutant or KMT2A rearranged leukemia. Around 40 plus patients were treated. So it's revumenib, which is a menin inhibitor, along with hypomethylating agent and venetoclax. So, and I think the overall um, this is, of course, a phase one study, phase 1B and 2. So the primary endpoint is to find an RP2D, which is like a recommended phase 2 dose. But of course, we're on the side, we also want to exploratory look for like what is the response rate in these patients.
So, was there anything about the demographics on this study that you would like to point out?
Actually, eh, pretty much the only thing that I was looking at is like there are relapse refractory trials, or even in the front line, there are some patients who were ECOG2, or majority of them, like a lot more patients allowed. Whereas here, it was just more of ECOG 0 and 1. If you look at it, majority of the patients are ECOG 0, 1, and very minimal number of patients are ECOG2. That probably is not what we see in the real life, with the other comorbidities. But again, it could be just because it was a newly diagnosed setting and performance status would have been probably better. But there are patients in the real life, like where ECOG would be lesser a diagnosis too. So I want to know how this would pan out in terms of that. But otherwise, I would think they are pretty much what I would have seen otherwise.
And what do we know so far about how the early data looks in terms of efficacy?
So the efficacy, the CR rate is definitely, dose level 1 and 2 and 3, dose level 1 and 2 looks promising, like 60 to 73% or so. So, it is definitely looking better in terms of, historically, these numbers I've seen. But again, this is not a direct comparison. Looks promising for now. And uh, what I want to know more is the MRD status, and how deep we can achieve this MRD, and what kind of MRD we are using. So if you look at you know um, I think the data from this beat AML shows that, like, there was 76% after cycle 1 and 89% after cycle 2, based on a flow-based MRD, which is quite promising. But again, like, what I'm more interested to know is knowing the NPM1 MRD by PCR, and making it more standardized and across more number of patients. Of course, here they did show that NPM1 mutation NGS was negative in around 31% of patients. So I wouldn't probably more interested to know based on more deeper level of MRD measurement, like by PCR. Um, but otherwise, I think these data will continue to evolve as we learn more about all these surrogate measures of deeper response.
And any safety signals that have come to the fore?
So, this is where it gets more interesting, is that, when we started using these drugs in the frontline space in combination, at least in ziftomenib, we did not find increased cytopenias compared to the doublet, that we have used historically. So, and I think it is not much different, but of course, you see that here, in revumenib treated patients, QT prolongation seems to be a bit of a class effect here, since it's not historically known with HMA venetoclax. But otherwise, the rates of differentiation syndrome are far lesser, especially because we are using a triplet, and maybe we are able to better cytoreduce with the HMA ven combination, and this probably helps further get their deeper remission status possible. But otherwise, and I think it's pretty common for other drugs in the same class. But here, the cytopenias may be slightly higher, but again, it's very low numbers. It's hard to say for now. I think across the space, it's probably not adding much cytopenias when combined with doublet like HMA-VEN.
And what do we know about the triplet in terms of longer term results?
Again, it's very early to say. So I'm not able to come to a real conclusion in terms of what is the impact on overall survival. But what is more important is, like, how many of these patients are getting to transplant. So, and I think if we make those numbers go higher up, and I think that will reflect in overall survival benefit on the long run, because the median follow-up time is pretty short in many of these early phase trials. Understandingly, like, they're all still maturing. But I think what is more interesting to know is to see how many of these patients are able to go as MRD negative CR into transplant and can maintain that post-transplant.
And so I guess ziftomenib is undergoing a similar evaluation in the Comet 007 study.
That is true. And there are multiple arms where ziftomenib is combined with both intensive as well as non-intensive treatment. What we are seeing here is the 600 milligram dose combined with hypomethylating agent and venetoclax. Again, there is a co-primary endpoint, which is CR rate and safety, and multiple other secondary endpoints. And the data cutoff here is September 2024, 2025, and hoping to see some of these publications coming out in this year.
And so, again, I guess a pretty typical population that you would expect accrued in this
Yeah,
study.
that is true. But I would just want you to pay some attention here, like that ECOG status of 2 is in 60% of patients accrued into the trial, which is kind of what you want to see in a real life setting. So I would think like many clinical trials would accrue more patients with poor performance status as well. And of course, it's a hard call. It's not easy to recruit many of the patients in that area, but it's promising to see that ECOG of 2 in 60% of patients are accrued into the trial. So it's kind of going to reflect what we're going to see in real life practice. But otherwise, demographics are pretty much okay. And of course, there's like a selected co-mutations displayed here. And what we see in real life practice is the IDH1 and 2 and FLT3. So it's what we see in real life practice.
And once again, early data on the tolerability, any red flags?
From here, what I could see is the differentiation that was reported in the relapse refractory setting is far lesser. And I would probably think it's because of the cytoreduction that happens with the doublet, hypomethylating agent and venetoclax, and possibly why you expect less differentiation here. Um, and Apart from that, nausea is a little bit, probably a side effect of ziftomenib, as we see is in the top list. But otherwise, what I would think about cytopenias, I think it's historically similar to what we have seen with the Ven and HMA combination, maybe a tad bit more or a tad bit less. But again, these numbers are too small to come to that conclusion. I'm not seeing an alarming signal that it causes like profound cytopenias with the triplet.
And what do we know about its effectiveness in early readouts?
Oh, the composite complete response is 86% as we see here, and the overall response rate is slightly higher. And these seems a bit more promising, but again, these are again like smaller numbers. But what is more interesting to see is the central MRD negativity rate of close to 70%. And if you dial it down further to 0.01% sensitivity level, it comes down to 44% or so. So, how soon they achieve these MRD negativity, and then the MRD negativity continues to deepen as the cycle progresses, is something good to know. But again, we actually want to know how much it is different between, just aza alone. So until and unless that results come out, it'll be hard to say like how much of these are clinically meaningful. But whatever we are seeing now are good signals, and hope this pans out in the same way when we try to compare that with aza alone versus the triplet. So if I'm hoping to see that the triplet would probably produce a deeper response and better MRD rates and better CR rates, and of course better overall survival rates eventually.
And anything else to highlight in terms of other data that has emerged from this study?
They have also elaborated about the count recovery time, and the patients who has had a composite complete response. You see that the ANC recovered above 500 in considerable number of patients, and then if above one is also like good number of patients. So I think what we can learn is like it's not probably delaying count recovery in majority of the patients. So and I think that's something good to know.
So obviously the others are also, though not approved for later line yet, moving into the frontline space. Bleximenib has a similar multi-cohort study, it appears, with multiple different cohorts. Looking at the Bleximenib with venetoclax and azacitidine, again, is there anything in the toxicity signal that emerges that is unique to this, or pretty similar to the revumenib and the ziftomenib data?
I would guess so. But I think so far what we have seen is not much of QTC prolongation. But again, like those are smaller numbers. When they go for a labeling study or a presentation, and that's when we'll know like probably what is the true estimates of QTC prolongations with this drug. But so far, like Bleximenib, we have not seen like much of unfavorable safety profile with respect to QTC prolongation. And it is not surprising because and almost all these drugs would have a similar combination strategy because, and I think that's where the field is moving towards too.
Yeah, I think you've talked about this, the QTC prolongation. Anything to comment on the differentiation?
So the differentiation syndrome is going to be an on-target effect. So in my opinion, how we manage that will be the question rather than the incidence of differentiation syndrome, because you want the cells to differentiate, but in a fashion that we are able to mitigate the side effects coming out of the differentiation, and also manage the adverse events or adverse toxicity coming out of it, like especially like high inflammatory cytokines and all those uh, you know end organ failure. You just want to prevent any of those things, but you want the cells to differentiate. But again, these numbers are pretty much similar to uh, what we have seen in the other combination studies. When you are combining, there is less differentiation and less serious differentiation, and I think it's promising because you get to achieve the effect of the drug at the same time, prevent any untoward side effects like differentiation syndrome.
And again, early data, anything that we see here that you'd like to comment on in the terms of the effectiveness?
Again, smaller numbers, but the combination does seem to be pretty effective. And I hope this is synergistic and going to yield better response than when an ASA alone. And I think there are signals to say that already across the board in the menin inhibitors in the combination space. My only wish is that signals should stay strong, and in comparing with the placebo with the same doublet, it should pan out to be better than the doublet.
And I guess still early data, but anything you can talk about at this stage on durability of this combination approach?
Um, Durability seems pretty good. At least, you can see like some of these patients continue to respond in the swimmer's plot. Um, but again, like you want many of these gains to be consolidated with more definitive treatment if they're eligible for transplant. But as of now, the signals seem to be pretty good, both in the relapsed refractory as well as the newly diagnosed. In the relapsed refractory, it creates an opportunity for patients who can maintain this remission for longer run and get to a definitive form of treatment like transplant if eligible, if not at least to get the maximum mileage out of these drugs.
So obviously, the other rational thing when you move it into frontline is to combine it with more traditional chemotherapy. I think that those trials probably will take a little longer time to read out.
I agree. Like these are registrational studies, randomized phase three, exactly what we have talked about, comparing it to placebo. And that's exactly what you want to know, how much of these drugs adds value to the traditional backbones that we have used, both Menin, hypomethylating agent and 7+3 backbone, and how much of it is influences pre and post transplant maintenance. And those are also, there is a second randomization in this trial
Or
using ziftomenib. So it is quite going to be interesting phase in the next 3 to 4 years. These studies are expected to last until 2030 or so for final accrual. And I'm excited as you, being in this space, because this last 6 or 7 years of menin inhibition has been very exciting and very rewarding for patients as well as physicians taking care of them. And seeing registrational studies is promising in this space, and hoping to see those results in the next 4 to 5 years, as and when we see any signals of response.
And obviously, as the field gets more and more targeted therapies, the question often becomes which one do you go after first? But then I guess another way to see is maybe you combine them. So, what is you obviously a basic scientist as well, and you kind of research this area. So, what's your insights into how we should go after patients with multiple mutations that are
That's a good
targetable?
question. Yeah. So, and I think there are two schools of thoughts. Many of my friends would probably hit all the targets with all the drugs that are available, provided if they can be safely given, or at least sequentially given. We need just be convinced like which is the founder lesion, or they are just like two different clones. Um, but if you look at the menin inhibitors plus FLT3, there is a clinical trial that is probably going to be, getting the results out pretty soon. They have accrued the numbers already, so waiting for what those results panned out in the relapsed refractory space, and especially when you're running out of options. And this are two different things. FLT3 being like inhibitor being a signaling inhibitor, and menin more of a transcriptional program regulator. And I think both together makes a lot more sense to combine them together. And especially if you have an NPM1 and FLT3 together, you probably want to think about combining those two inhibitors. But what could be, challenging at the same time attractive is that once you start combining these drugs, especially these small molecules, there is always going to be some challenge in how we're going to dose with the dose drug-drug interactions. And many of these drugs also will have, being a CYP3A4 substrate or inhibitor. So you might have, challenge getting other drugs on board, especially antifungal therapies. And many of these patients would require such. And if they have additional drugs on board from their chronic comorbidities, it's going to make it a bit more interesting and challenging in how we're going to do that. But I think we have navigated such challenges in the past. If you look at venetoclax and antifungal therapies and other drugs that could, and we have done that safely, and we have combined venetoclax and hypomethylating agent and FLT3 inhibitors, which also has many drug-drug interactions needing dose adjustments accordingly. There's going to be a lot of learning curve when you start combining many of these small molecular inhibitors, and especially there may not be any uniformity in terms of how we manage these patients. And in that regard, of course, having constant updates about these practices and how I practice, kind of readout from experts would help convey the message how we're going to treat these complex molecular signatures.
So obviously for KMT2A, which has a really bad historical prognosis, this is a paradigm shift. For NPM1, these patients have not been treated as a homogeneous whole in the past. Do you think these drugs now bring a unifying strategy, or do you think that in the relapsed refractory setting where we are today, there is still going to be patients who will be managed according to co-mutations, or even given chemotherapy for some patients before they're exposed to menin inhibitor for NPM1 mutations.
That's definitely a very interesting question. Like menin inhibitors historically thought it should just work in KMT2A-rearranged leukemia, and then it was very fascinating to find that like it was pretty sensitive in NPM1-mutant AML. But I think it is just not mutation agnostic. It just goes by sensitivity signatures across the board. There is expanding space. Even one of these menin inhibitors are being explored in NUP98 rearranged leukemia. So there are more scopes of expansion in this space. If you look at KMT2A rearrangement, I want to put that in the separate box because it still carries a very bad prognosis. And of course, menin inhibition by itself is not going to cure it. You still need a salvage transplant, but what is more promising is that these patients are able to get to CR, and possibly like we have not measured it yet, and that's why I'm saying possibly they are getting like a deeper MRD with them, and then they can potentially be taken to transplant. When it comes to NPM1, if you we all know that like NPM1 by itself is good prognostic, just by itself. But nevertheless, like we are going to face, or we are already knowing that NPM1 doesn't come by itself. Many times it comes with different flavors of other molecular signatures, including IDH, including FLT3, including like KRAS, including many other WT1, like for example. So it is a paradigm shift in general, but in NPM1, I would still think it has a major role to play when we have complex co-mutations that exist. Um, how this is going to pan out, because we know that from retrospective studies that were published in 2024 based on clinical trial data from UK, that co-mutations do influence the NPM1's recurrence. But if they're able to get to NPM1 MRD negativity within 2 cycles of intensive therapy, then the influence of those mutations is far lesser. So, and in that regard, like menin inhibitors, if they are able to get these patients to NPM1 MRD negativity quicker and deeper, my extrapolation is that like you're probably going to reflect that in good outcomes in even in these patients, though they are good prognosis. But of course, like in pure NPM1, the prognosis seems better, but there is some number of patients who do relapse. For them, it's an opportunity, and with this expanding armamentarium that helps, navigate relapses and hopefully take them to transplant in those situations, getting them to a complete response or a CR with MRD.
Well, I really wish to thank you very much for taking the time out from your busy schedule to talk to us about this exciting area that is clearly a passion of yours, and obviously a great time to be in this field. If you have a passion for menin and studying its effects, I hope I can get you back to talk to us about this and other topics as well in the future.
Absolutely. Pleasure was mine, and thank you for having me and allowing me to share my thoughts about menin inhibitors. It's been an exciting time for AML management in the past 6, 7 years, especially, and more to come. And I'm really glad I'm being part of this journey.
Thank you very much.
Thank you.